because of increase in fibrinogen and pro-inflammatory mediators. Smoking, okay. Smoking causes deposition of low-density lipoprotein and use of oral contraceptives, okay. That one you've already said that because of increase in fibrinogen and obesity, all right. So we see that increase in coagulation factors such as fibrinogen, prothrombin, and factor 7A, factor 8A, and factor 10A. Then there's increase in platelet and their adhesiveness. All these can contribute to hypercoagulable state. The other thing that you need to ensure that you always remember, especially for patients who present with who present with nephrotic syndrome, is loss of the natural anticoagulant that is known as the antithrombin 3. So this antithrombin 3, when it is lost, all right, when the patient is losing a lot of proteins, so this patient may end up being predisposed to deep venous thrombosis and pulmonary embolism. Hypercoagulable, age, malignancy, all these nephrotic syndrome, we say that loss of antithrombin 3 nephrotic syndrome can all lead to deep venous thrombosis. The presentation of DVT will have typical features, and this one includes pain and tetanus, swelling, especially unilateral, redness, warmth, edema, sometimes cyanosis. When you do your Homan sign where there is dorsiflexion of the foot while foot is extended, usually this one is not allowed because it can withdraw. It can dislodge the thrombi. Then you have positive Homan sign. Local examination, when you inspect, you see there is erythema. Sometimes you have color change and swelling. Okay, this is about the wound. All right. Check for tenderness, any discharge or warmth while palpating. Remember to palpate the distal pulses, that is dorsalis pedis and posterior tibial, and evaluate capillary refill to assess lymph perfusion. Okay. Always palpate the deep pulses, that is dorsalis pedis and posterior tibials, to evaluate capillary refill and assess lymph perfusion. Palpate all joints. All right. Neurological examination is important to be able to detect any nerve root irritation or sensory, motor, and reflex deficits. Okay. Always remember to search for signs and symptoms of pulmonary embolism. This includes tachycardia, which is very common, tachypnea, difficulty in breathing, or chest findings, which are rare. All right. So edema, right, as you can see, this is one leg, this is another leg. Okay, so both legs are edema, right? So you should be able to identify a patient with DVT. You can see all the way extending up to this level. And this one also, as you can see, there's actually cyanosis, okay, or peripheral cyanosis. And there's also some patchy cyanosis, especially going down the foot. Diagnosis of DVT, so history and physical examination. Of course, the patient will come with pain. It's characteristic of cramby or Charlie horse pain, the lower calf. All right. Then you have a differential diagnosis of DVT or unilateral lower limb swelling. This is ruptured Becker cyst, cellulitis. Usually with ruptured Becker cyst, the patient will have extreme pain. Okay. Cellulitis, Patient will present with history of trauma, and there could be some discharge as opposed to DVT. Trauma in itself, history of trauma is very important, post-traumatic syndrome and venous insufficiency. Okay? We say that for sudden and severe cup discomfort suggests a rapid check. We present with history of focus of infection or trauma. All right. The best criteria should be one of the criteria that you are able to use for you to be able to make a diagnosis. And this one is a number or the criteria that is used for you to be able to characterize the risk for developing deep venous thrombosis. You have the clinical variables here, and then you score. If you have active cancer treatment for the last 6 months, you give 1 point. You have paralysis or paresis or immobilization, 1 month, 1 point. Bedridden, 1 point. Local tenderness, 1 point. Swelling of entire leg, 1 point. Calf swelling more than 3 centimeters, 1 point. That is the reason why you're supposed to have a tape measure. Pitting edema, 1 point. Collateral superficial vein and varicose, 1 point. And previously documented DVT, 1 point. Right. If you have an alternative diagnosis such as Becker's cyst, then you remove 2 points. When you add up your points, 2 points is equals to DVT most likely. Perform ultrasound. Okay. Low likelihood of DVT if point score is 0 or less than 2. Moderate likelihood if score is 1 to 2. High likelihood is 3 or greater. All right. So make a okay. Less than 2 points, we say that DVT is unlikely. All right. So I was just making a correction here. Sorry. Diagnosis. Gold standard is what we call the intravenous venography. But in most cases here, in our situation, we normally don't do intravenous venography. Perhaps a young person or even a patient to do venography will not always agree. You use your epididymis, very important. All right. We say that venography is rarely used because it is invasive. So our patients may not want to undergo this venography. The other procedure that is normally used so much in our situation is a Doppler ultrasound. Right? Doppler ultrasound. Right? And an MRI in contrast. But Doppler ultrasound is the one that is normally used, especially now in our situation. Your clinical examination, the blood test for hemogram, you're looking for platelets, increase in platelets, increase in red blood cells. So increase in the red blood cells, all right, might lead to hemoconcentration, all right. A full hemogram, when you're looking at the platelets are important, especially in coagulation. And therefore, you're also looking at the platelet level, which is important. INR, international normalized ratio, is important for you to be able to check especially certain clotting factors, okay? And it is important for you to be able to do your INR. The reason is because of the certain clotting factors that are usually affected by warfarin. You are going to read about the DIME, Doppler ultrasound. I think we have talked about it. You're going to read about the limitation of use of Doppler ultrasound. Say that it is expensive, it is user dependent. What do I mean by user dependent? Let me explain about this user dependent. Now, when you're doing or you're carrying out a Doppler ultrasound, there's something called a probe that the user usually uses for it to be able to beam images, all right, back to the screen. So what happens is that if the user does not or is not able to beam the images correctly and be able to maneuver the probe, then the information that you're going to get on the screen may not be accurate. You can also do your magnetic resonant imaging, okay, together with contrast. All right, now this one usually gives a very clear picture, okay, it can be able to help you to diagnose DVT. And this one actually gives you a clear picture that you can be able to diagnose DVT in the leg, pelvis, and pulmonary thrombi. And it's usually 97% sensitive and 95% specific for DVT. All right. MRI without contrast is safe in all stages of pregnancy, but it cannot be used in pregnancy. Treatment, non-pharmacologic or supportive. Always ensure that the patient is ambulated for you to be able to avoid cases of stasis and immobility leading to DVT. You can use what you call intermittent external compression stocking so that you can, this one, they increase the velocity of venous return, all right? Therefore, what happens is that they help in moving the upward flow of blood back to the heart. Pharmacologic, you use anticoagulation. I'm not going to talk about these intermittent stockings. I want to move as fast as possible. So we say that treatment strategies here include anticoagulation, thrombolytic therapy, surgery, filters, compression stockings, okay? Anticoagulation, start with heparin, okay? This one prevents extension of the thrombus, all right? So usually given as a subcutaneous, okay? All right? Anticoagulation is use of heparin. And the heparin that we are using is what we call the low molecular heparin, okay? Low molecular heparin, or otherwise called Clexane, all right? The dose of heparin, the normal heparin, is usually 100 units per kg body weight. And it's supposed to be given at least twice per day. When you start giving heparin, it is supposed to be at the same time to be given together with warfarin. Then you start doing your INR. So warfarin and heparin are usually given simultaneously. If you're going to give Alan, nini? Nimeanza saa ngapi? Alan, na wewe unajua wewe ni mkora, mbona hujaniambia? Oh, sorry. Let's continue. So I give simultaneous warfarin and heparin together with the two of them, so you overlap. Okay, so you say that the dose of heparin is 100 units per kg body weight and is supposed to be given twice per day. The dose of warfarin is about 5 milligrams. Okay, so you need to do your INR. If you're going to give Clexane, okay, so if you're going to give Clexane, the maximum dose of Clexane for an adult is about 40 international units, right? It's supposed to be given OD or BD, all right? APTT is the laboratory test that is supposed to use to monitor heparin therapy. INR is a laboratory test that is supposed to be used to monitor warfarin, okay? So these are the difference between low molecular weight and high molecular weight, or what we call unfractionated heparin, okay? All right, so we use low molecular weight heparin because it's usually very stable, okay? Superior bioavailability, it doesn't require laboratory monitoring, less thrombocytopenia, all right? All these, yeah? When you're giving warfarin, it interferes with vitamin K dependent coagulation factors such as factor N, 9, 7, 2, protein C and S, okay? All right, so it should be individualized, okay? So when you're carrying out INR, remember that you are monitoring the effect of warfarin. The INR should be between 2 to 3. The normal dose is 5 milligrams. You can also do thrombolysis, all right? So this one is a clot busting therapy. It's supposed to be used especially if you want to do what we call prompt resolution of symptoms and prevention of pulmonary embolism and restoration of normal venous circulation, okay? So clot busting using thrombolysis. They include streptokinase, urokinase, and tissue plasminogen activator, right? If you have a lymph that is being threatened by ischemia, then it is important. If you have proximal iliofemoral DVTs, then you can actually use this thrombolytic therapy. Okay. Surgery, when anticoagulant therapy is ineffective, unsafe, or contraindicated. All right, so you end up removing the clot. And of course, if there's also partial interruption of inferior vein cava, and this one may lead to, if it is not done, can lead to pulmonary edema. So you can see the way these clots are forming. They are so big, okay? All right. So you can imagine if that one goes into your lungs, this one, the whole of this. All right. And imagine the whole of this is a thrombus. Filters for DVT. Inferior vena cava filters to help reduce the risk of pulmonary embolism by trapping large clots and preventing them from reaching the heart. So these ones, once a patient has been diagnosed, or especially for patients who present with malignancy and they present with DVT, filters are very, very important for them. So indication for filters, we say it's for prevention of pulmonary embolism, okay? And a patient who is contraindication to anticoagulation. And if a patient has a history of pulmonary embolism despite adequate anticoagulation. These are the controversial indications, right? Compression stockings are very, very important, okay? a lot of information here which I think you can read on your own. Something that I had not put here, which I thought was part of my notes, was the newer treatment that we normally, the newer and oral anticoagulants treatment known as DOACs or NOACs, right? DOACs or NOACs that are normally used for management of pulmonary embolism and also DVT. These are newer oral anticoagulants known as DOACs or NOACs that are used for management of deep venous thrombosis or pulmonary thromboembolism. Instead of using heparin and warfarin, the newer oral anticoagulant therapy can actually be prescribed, and they are usually very safe. They don't need recurrent monitoring, right? And therefore, these are the drugs that are newer in the market and should be used, right? Examples include rivaroxaban, which is normally given as in acute situation, is normally given as 20 milligrams twice per day. Then for about 3 to 5 days. Then you can reduce the dose to about 15 milligrams once per day, right? For about 3 months and review the patient. For patients, when you're treating DVT, for patients who are having what you call the proximal DVT, you're going to treat them for about 6 months with oral anticoagulants. For patients who present with distal DVT, you're going to put them on oral anticoagulant for about 3 months. When you're talking about distal, we are talking about DVT that is affecting the calf muscles. All right. Thank you. Any question? There's a lot of information that I have skipped that you should be able to read on your own, because I didn't want to go through that. I'll try also to ensure that I reduce a lot of information that you don't need in those slides, so that you can remain with what you think you need. And also I'll be able to put some slides on DOACs and NOACs, the newer oral anticoagulant therapy. I want to stop there. Unless somebody has a question.